the next patient we had in our series was little Matthias. He is now 15, and he was treated for medulloblastoma at the age of 2. He was operated, he was irradiated, and even the mother thought that might be, well, they choose to let him survive and be operated, but the consequence was severe cognitive disabilities, reduced learning, short memory, speech problems, problem with attention, dry mouth, and you can also see here on the imaging that's a large defect, and also in the vision area. We performed a multi-neurologic test, PET CT scan. His mother made notes on what was going on, and he was seen by eye doctors. He was given 30 sessions, 5 days a week, 5 minutes compression, 90 minutes on hyperbaric oxygen, 2.8 ATA, and 5 minutes decompression. And after the first series, he got unaltered metabolic activity on the PET scan. The neurologists showed a slight increase in attention, less tiredness, slightly better memory, and the electroretinogram was faster than previously. And his mother that describes as his previous social isolation was not a major problem anymore. So there was a discrepancy between the neurologists and the imaging and the observed value of life. However, they also wanted to come back a year later. That was part of the arrangement. So the improvements in this case seemed to be stable. He didn't step one step backwards. His social context, he was improving. His double vision was of less importance. His memory had improved, but he's a young person, and if he could get a better life, that would be a good advantage. So we gave him again 30 sessions, same recipe, and the present status is that his double vision is less. The neurologist finds a slight improvement. The patient is now reading books and doing that voluntarily. And he has started some type of martial art, which requires quite a lot of attention. And you saw the lesion in his brain was quite extensive. The 19-year-old woman was treated when she was 10 to 12 years by cerebral radiation, vincristine, and you can see extensive lesions also. Extremely tired, and therefore, as she had to sleep every day on the middle of the day, she really had problems with education, and she was also given a full public wage, as it was not considered she would be able to work at any time. The treatment was, as previously described, 5 days a week, 2.8 ATA, and here we have a alteration, the motor proficiency scale here before quite low figures, and they are increased to considerably after the treatments, which is in accordance to her behavior, general behavior. So this half year later, she's less tired than before the hyperbaric. She is able to follow school on a daily basis. Usually it was 1 or 2 days a week. Able to walk 5 kilometers, previously only 100 meters or so. No sleeping in the middle of the day, no alteration of vision. We can find no alteration on the imaging, so that means that we have to improve that, and the more delicate psychology tests are to be finalized. Our colleagues, fortunately, also shown today, are working, and various studies reported about the ability for oxygen to make a difference. And last year, I got a good talk in telephone, very inspiring, and today we got the reports. We have plans about what to do, because this is a major importance to the public health, to the patient's health, to general society. So we want to make randomized control studies following the usual lines. We use 2.4 ATA, and now some colleagues have other types of study projects, and now we're coming with HBO, which really breaks their way of thinking, what's intensive. So we have 2 project lines now doing something about imaging studies together with neurosurgeons, and traumatic brain injury along with the trauma surgeons. But how come that patients seem to obtain clinical improvement after 3 years, after 12 years, after 7 years? Are we treating long-lasting inflammation, endothelium defects, or stem cells coming along? A lot of things are going to be exposed. So we know that at least a few patients I've described here, we had changed their lives, and hopefully find new ways. And a big inspiration have been the visits of Rami, and I look forward, so you still will be our visiting professor in Copenhagen. Thank you for your attention.
Give some time for questions.
Yeah, we have plenty of time for discussion, the questions. Yeah.
It is very good that this kind of experience, it's not only in Israel, it can happen otherwise around the world. There are 2 things that are very important when you're looking at or speaking about hyperbaric in the setting of traumatic brain injury and stroke. First of all is what we spoke, to choose the appropriate patient. Okay, you need to choose a patient that have the mismatch between the metabolic and the anatomical evaluation. This is one thing. The other thing which is also important, for example, the woman who had the convulsion, we are treating patient with traumatic brain injury at 1.5 atmosphere, not more than that. There is no need for more than that unless you have a vascular problem. In the stroke, we are using 2 atmosphere, not more than that, because there is a vascular problem usually, so that's the protocol. Another important thing, when we have done the pilots, different pilots, the minimal serial of treatment should be 40 and not less. Today, we are not even giving 40. During the study, it was 40. Today, we are giving 60, because all the metabolic pathways in the brain takes time. And today, when a patient is coming, we are saying that if you're not going to get the whole 60 session, we are not starting. Because we know that all the process that you initiate takes that time. And you may miss a lot if you are giving it in a 30 session period. So these things need to be more learned. And I hope that like we are doing, we can collaborate more and learn more by that. But it's very important, the amount of oxygen that we are giving, and we don't need higher amount. Remember from the lecture yesterday that Asaf gave, in the mitochondria, it's 2 atmosphere. That's all. Okay, the amount of session, and to choose the right patients. If you have necrotic, we can do nothing, unfortunately. Okay?
In some 30 years ago, when I started hyperbaric therapy, doing hyperbaric therapy, we had a huge problem. We were trying to attract patients, and nobody wanted to send us patients. So Yuda still remembers that we used to be called to, especially the near trauma center where we worked, and asked to treat patients, and we would say, well, we don't know. We really don't know if it'll help. But you know what? We can't say no. So we'll take that. And I think that 30 years later, we should not be at that stage with hyperbaric therapy. And no other therapy I can think of would be provided to a severely disabled patient without an appropriate, prospective, well-validated, staged approach to research. So why do we still keep doing that? Because the soldier is fighting for his well-being? I mean, we're happy he is, but we cannot provide him therapy just because A, it's probably not dangerous, and B, because we can. So the point I'm trying to make is that it's high time that any such question, which is so extremely complex to answer, so expensive, and so multifactorial, should not be approached anymore on a case-by-case basis, but should only be approached and only be provided if it is provided in the context of a well-structured prospective study. Otherwise, it should not be done, period.
Yeah. I fully agree that the time has come, and especially at this meeting, that we have substantial information to make that type of prospective studies. We still have the dose response relationship to be determined, but they are minor things. I think it's really essential to focus on what we know now, and from that make the randomized control studies, and then we can fiddle the knobs afterwards concerning whether it's a 55 or 60 or whatever. Is it once a week, once a day, or whatever type? But we have to stick to the protocols. So I hope this casuistic messages is one of the last of the series, and the next will be the more structured information. I fully agree.
I would like to make a note about the fact that in some cases you didn't see any change using the functional imaging. Using functional imaging, it's a complex process, and comparing pre and post HBOT images is not a trivial process. There are many factors that you have to take in consideration while comparing the images. First thing, you have to normalize the images to one study in order to see visual changes. And sometimes even visual analysis is not enough. You need to use a dedicated software that can compare the two sets of studies in order to see the images. And the images you showed are only one slice, none, I don't know if they were normalized or not to the previous study, and certainly they were not processed in any way by computerized software. So we can see the actual change in certain areas.
Actually, the pictures were normalized and they were computerized, but I just wanted to give the conclusion of those. But of course, by increased experience, you will get more detailed responses. That's evident. Yeah.
Thank you, Jansen.